Have you ever encountered a pediatric patient with sudden purpuric rash and wondered what organ system might be silently involved? In this video, we will explore the clinical presentation, diagnostic criteria, and management strategies for Henoch-Schönlein Purpura or HSP. Let's dive in. Do you know which symptom is most likely to bring a child with HSP to your clinic? Yes, skin manifestations. The hallmark is palpable purpuric rash, often starting on the lower extremities and buttocks. Why it is non-blanching? Because it's due to a small vessel vasculitis and extravasation of red blood cells. Second symptom is joint symptom. Over 80% of patients will present with arthralgia or arthritis, particularly of knee and ankle joint. It is transient but distressing. Third symptom is gastrointestinal symptom. Up to 50% will experience with colicky abdominal pain. Here the catch point, GL symptom may precede rash. Could you miss the diagnosis? Fourth is renal involvement. Approximately 40 to 50% develop renal manifestation ranging from nephrotic range proteinuria to hematuria. How confident you are monitoring for the progression? When faced with child who fits the clinical picture, what's your next step in confirming the diagnosis? HSP is primarily a clinical diagnosis, but let's break down its key clinical criteria. Characteristic purpuric rash plus at least one of the following: abdominal pain, arthralgia or renal involvement. Example is hematuria or proteinuria. Laboratory workup. Look for elevated ESI and CRP as inflammatory marker. Check urine analysis for sign of renal involvement. Definitive confirmation, a biopsy showing deposition in a small vessel seals the diagnosis. But what do you need? We need biopsy always. Now the treatment strategies. Once you diagnose HSP, what's your treatment plan and how do you decide if the patient needs steroids? Supportive care. Most cases are self-limiting. Ensure adequate hydration and pain control for arthralgia. Corticosteroid indicated for severe abdominal pain, GI bleeding or significant renal involvement. The dose is prednisolone 1 mg per kg for 1 to 2 weeks with gradual tapering. Renal specific treatment in cases like nephrotic syndrome or RPGN. Consider adding other immunosuppressive drugs like azathioprine, cyclophosphamide. Monitoring. Regular follow-up with urinalysis and renal function tests are non-negotiable. Do you know that up to 10% patient of HSP may progress to chronic kidney disease? How do we prevent this? Most patients fully recovered without complication. Complication to watch for: chronic kidney disease in severe renal involvement, recurrent episode of HSP in 30% of patients, often milder but still concerning. Key message is early diagnosis and appropriate management can prevent long-term morbidity. If the next patient you see present with rash, you will consider HSP early and ensure you will monitor for renal complication. If you find this breakdown helpful, like, subscribe and share with your colleagues. Let's keep learning together.